Welcome back to another episode of the Dissecting Medicine podcast. My name is Jesse. I am an applicant to graduate entry medical school. And in this podcast, I speak with clinicians, researchers, and people from health policy. And we discuss career planning as well as what it is that drew that individual to their specialty to hopefully give a little bit of an insight into the decision-making process and also give people a realistic view of exactly what practicing medicine in different fields looks like. Today's guest is Associate Professor Riitta Partanen. Riitta is the Director of the University of Queensland's Clinical School. Before that, she was also the inaugural Director of the University of Queensland's Hervey Bay Clinical School specifically, but now manages their entire rural clinical schools across the state. As well as that, Riitta is also a practicing general practitioner in the Maryborough-Hervey Bay region and also has a number of different roles across the university as well as in research in rural medical workforce and rural health and general practice issues. Dr. Partanen is a fellow of the Royal Australian College of General Practitioners. She's also completed a diploma in Obstetrics and Gynaecology through the Royal Australian College of Obstetricians and Gynaecologists after completing her Bachelor of Medicine, Bachelor of Surgery at the University of Queensland. I really enjoyed the conversation that I had with Riitta. We had a relatively limited amount of time and there were a few technical issues before we got started, which is why the beginning I might have sounded a little bit rushed. Hopefully I got through that relatively smoothly, but she was able to offer a huge amount of insight and it was very, very eye-opening for me personally. So hopefully you're able to get something out of the conversation. Anyway, without further ado, Associate Professor Riitta Partanen. Okay, well, very whirlwind start to the podcast today after a few issues. Thank you so much for being on the podcast today, though. I just wanted to personally thank you because I know your time is obviously very, very valuable. And so I really do appreciate you giving the time out of your day today to chat through. I might start off just to do a quick kind of introduction to the audience. I think you're probably better than me at introducing yourself. So if you don't mind, maybe just detailing a bit of who you are, what kind of roles you hold, and then we'll go from there.
Yeah, sure, no problem. So yes, my name's Riitta Partanen. Have a couple of roles that I do. I'm a GP. I'm a GP in Maryborough in Queensland and have been working in general practice for 26 years now, so just a little while. And I also work for the University of Queensland's Rural Clinical School. So my current role with them, and has been for the last 2 years, is the Director of the Rural Clinical School for the University of Queensland. But have worked with UQ since 2005, being the inaugural director at the Hervey Bay Rural Clinical School site when it first started in 2005 and was in that role until the end of sort of 2020. Yeah. Okay,
so those are separate roles because I was thinking you were maybe still director of the Hervey Bay one, but so you've disconnected from that. So now you're director of the entire
whole,
kind of rural clinical teaching.
Yep. That's correct. So we have our students from Rockhampton, Bundaberg, Hervey Bay, Toowoomba, and then across the lower half, sort of the rural communities in the lower half of Queensland or the southern half of Queensland. And but I'm still based at Hervey Bay when I come to work for the university at the Rural Clinical School in Hervey Bay. So, but yes, I was the director there for quite a few years, so it still feels like my home base as well.
Yeah, fair enough. And it must be pretty difficult as well because I get quite confused, obviously being a Melburnian, I'm very naive to the geography of Queensland, but being such a large state, that must be quite a challenge in terms of orchestrating the rural clinical schools across such wide areas. And I'd imagine we'll get into probably more detail about Hervey Bay specifically maybe, but I'm sure there'd be a lot of uniqueness to each of those clinical schools and the kind of subpopulations that you're working with as well. So that must be quite a challenging process to direct and orchestrate.
It is. We've been doing it for 20 years now. So not myself personally, but the organisation. So we are quite used to working in a distributed, way so that despite there being the challenges of distance, thankfully, technology allows us to be able to communicate on a regular basis. And in fact, probably one of the benefits of COVID is helped our metropolitan-based colleagues work with Zoom and meeting etiquette and so forth a lot better as well, so that we're not, they actually understand and appreciate the challenges of Zoom when we used to Zoom into meetings. So into Brisbane, into the central, location as well. But I think, from a point of view of even though the communities are quite far apart, there's lots of similarities to regional Queensland, certainly in the Wide Bay region. The demographic is quite a elderly population, also a low socioeconomic community. Rockhampton, being in central Queensland, has got quite a lot of an agricultural and mining kind of community, has a lot of younger people working there as well. And then Toowoomba is a community that's quite an older community, has also obviously the rich, agricultural surroundings there, as well as being the entry to the mining sector in the southwest. So there's a mix of things, but overall, I think from a clinical school perspective, there's not that much differences for us running the program across the different sites. There's still a wonderful breadth of pathology and cases that come through the regional hospitals, and for our students to ensure that they see all the kinds of things they need to see and learn about, to be safe and effective clinicians. So whilst there's variations, I think, common things occur commonly, and the core bread and butter that medical students need to understand well and learn happens across, I'm sure, across all sites, and not just across UQ's footprint as well. And then, but yes, there, distance means a bit of travel to get to Rockhampton for me to travel up there and then out to Toowoomba. I'm kind of centrally located here in Hervey Bay, so it's not quite so bad as well, to be able to travel to my sites as well.
But I guess that, as you said, like the pandemic probably did accelerate that process of normalizing digital communication, and that's probably made things, it's probably really just an advantage, if anything, to take advantage of, because you'd have greater interconnection between the schools and between the departments. So no, it's definitely helped us, I think, and many more meetings occur on Zoom now, and not just us zooming into a room full of people. Everyone's now on Zoom, so it makes it which makes a much better functioning meeting as well. So yeah, cool. And so I was going to ask as well, if were you still practicing general practice at the moment, or are you working with the uni?
I do. I feel like the ethos of the Rural Clinical School, and the reason we're funded through the Rural Health Multidisciplinary Training Grant, is around improving rural medical workforce. So I think I'd feel like a little bit of a hypocrite if I didn't actually continue to provide medical care to a community, in my community of Maryborough, which doesn't have enough GPs. And if I left that as well, I would be I would be adding to the problem. So for me, I feel like, to do this work and encourage others to work in rural areas, I feel like I need to, but I actually love my clinical work. So I would not want to give that up as well. So I still do work about a day and a half sometimes, some weeks not at all, because of just depending on the university, commitments and travel and things. So, but probably average out between a day to a day and a half a week, which makes my week pretty nice and variable. And I really enjoy my general practice days.
Yeah. And I'd imagine it's probably something that you could never really walk away from. I feel like, especially with general practice, because of the relationship that you have with your community and with your patients, that would be something that you would always want to hold on to and have as part of your weekly routine. I'd imagine that's something that you don't really have an end date in mind to. It's just something that will always be a part of your life.
Yeah, I think so. I have no plan of ending it anyway. I mean, you never know what's around the corner, of course, in life. But no, I've looked after some of my patients now for 26 years, and they've been on my journey through my life for 26 years as well.
They probably know you very well.
And they know me very well. So, it's nice to have that group of patients that I've looked after for a long time as well. But at the same time, I still continue to have some newer patients along, and obviously people come and go and leave the community as well. So but it is nice. And I think that's the joy of general practice, is that continuity of care as well, and following people through their life course and being them through the times of wellness, through times of sickness, through times of grief, and all of that happens in general practice that we come across. And I think it's a real privilege and honor to be on the journey with these people and through their lives, and trying to do your bit to help them to have the best quality of life possible, given their circumstances, their health issues, those sorts of things. We can't magically fix people, but we can be helpful along their journey and try to do what we can to make life a little better, easier for them, from the health perspective.
Yeah. And I think that's a really good insight, because for me as an applicant, like I've been thinking a lot about why is it that I'm pursuing a career in medicine. And so I'm going to be 30 this year. So I'm an older applicant, but not one of the oldest. We know that we have with graduate entry. That's the great thing, is people can make mid-career switches. And for me, I've spent the last 12 years being a high school tutor, actually, mostly to high school students. And personally, I think I'm quite naive to general practice itself. But I think that what drives me is, I just kind of related a lot with what you were saying there, of the idea of the privilege of being able to be involved in someone's life for such a long time. And I realized that's what drew me to tutoring and education, was that I could be involved in a student's life throughout their educational career, and often stay in touch and kind of in contact with them through to their early careers as well. And it's an interesting thing that I'm kind of contemplating. And it was literally just as you said that, and I knew this would happen with these kind of conversations. I'm quite naive to the practice of general practice. And so I've always not really seen it as something that personally entertained me, or like it was not really something that was kind of on my radar, but I also knew that I didn't know much about it as well. And it's just interesting that just that one thing that you'd said there, I was just like, that clicks with my kind of personality, and I should really give that more thought. And I wanted the conversations to do that for me, and hopefully for other people listening as well, because until you speak to a GP or you speak to someone in their field, I feel like that's one of the best ways to get a good insight into really what it means and what it's about. So thank you for that.
Yeah, it is. I mean, I think it's that privilege and honor, but it's also really interesting. Some people kind of think, general practice, you must see the same kinds of things. It must be, the justice script consultation, and you see lots of colds and things. Well, thanks to COVID, we don't see much colds at all because no one's allowed in the practice. No.
Through telehealth now, yeah.
Not quite. We are allowing them back in the practices now if they're negative and so forth. But, it is that real... the ability to, if you keep thinking, I think about how can you help this person, no matter if they're just coming in for a repeat script, is making sure that you've done all the preventative checks are up to date, that you take the opportunity to do what you can, your knowledge and your expertise, to make sure that that patient can be guided to help their health care as best as possible. And it's not just me telling people to do stuff or what have you, it's a journey with them, as in, they need to take responsibility for their healthcare as well, and I'm there to guide them through that and give them the expertise when they need it, and give them the care that they need. But they need to be part of that. But it's also really varied, general practice. A lot of people, if I think of my day yesterday, I had a mix of cases, from infants, from babies, to their immunizations, obviously COVID immunizations and flu immunizations at this time of year still, but I had a variety of excisions to do, including I do a lot of flap repairs as well. So I do those procedural skills, we do a venous section for our patients who've got hemochromatosis, management of, common conditions, your usual hypertensions and diabetes, but you're also following up your patients who've got cancers, and it's a real mix, and yes, your brain's kind of flipping from one thing to another every patient, but it is what I enjoy about general practice, and it certainly keeps you alive and interested, and you're definitely not seeing the same thing every day either.
Yeah, that's really interesting, because this is where I kind of admit that I'm very naive to the practice. And so to hear there's so many kind of hands-on procedural elements to it as well is actually personally quite surprising to me, but it's a good kind of surprise, because as an applicant, I'm not really willing to commit myself to one particular specialty, and I kind of expect it's going to take me a long time. And I kind of have a feeling that there'll be a moment where I get like a gut instinct almost. I'll experience something and go, this is really what it is. And the one thing that I know about myself is that I don't think I actually have a short attention span. I think I just like a lot of different things. And I wonder whether or not that's something that general practice can actually really play to as well. The idea of being interested in lots of elements of health.
Yeah, I think so. I think it really does. And yes, we have the 15-minute kind of consultation, I suppose. Sometimes shorter, sometimes longer, of course, but if you average it out and you're flipping between things, I actually find in my university work, sometimes I get to probably about 15 minutes and I've got to change topic because I'm just so used to kind of, I'll go check another email because I must be working too long on this particular topic. There must be something else. I find that I have multiple things up and I go, that must be my general practice brain coming in here, used to kind of flipping between things as well. But just when you said around, you're not sure what your career path will look like, and that's perfectly fine. And when I entered medical school, I thought I'd probably be a pediatrician. That's what I was thinking that I was going to be. So this is before, at the start.
So at the top of my list at the moment is pediatrics.
And so that was kind of what I thought. And then as I went through my medical program, every time I did a placement, when I did general medicine, I went, geez, I really enjoyed this. And then I did surgery, and I really enjoyed that. And then I did psychiatry and I really enjoyed that. And then I did obstetrics and I really enjoyed that. Did pediatrics, and yes, I did enjoy that. And you just keep going through the specialties.
The list grew.
And I just enjoyed everything. And so at about the end of medical school, I kind of hadn't cancelled anything off my list of career pathways. And then as a junior doctor, I had the opportunity to be able to do a lot of good general terms and enjoyed things. And certainly, I remember as an intern under my surgical registrar, I was the lead in taking an appendix out. I took the appendix out under their supervision, and it was just so exciting to think, I'm, knife to skin, this is my responsibility here, and I'm doing this all. And it was a very, it was a real buzz, and thought, oh yeah, this could be something I could do. And once again, when you're delivering babies, it's an awesome, obstetrics, I've always thought every time I've delivered a baby, it was an awesome experience, and just went, wow, we've brought this, the mother's done all the work, of course. I'm not taking credit for all the work the mother's done to deliver the baby, but at the same time, you've been a part of that to make sure it's come out safely or as best as possible. And then, the joy of that new life is just pretty exciting stuff. And when I was a junior doctor, actually in Maryborough, I was a junior doctor there for a couple of years, and I did 6 months pediatrics, which I really enjoyed, and 6 months obstetrics, and did my diploma of obstetrics and gynaecology, and wondered if I might go into that pathway actually in the end. But in my mind, I really just love everything. And for me, I think as well, so when general practice gives me that, even though I may not be as procedural as a general practitioner, but I get to still be in all the different parts of health. And I think, that during those junior doctor years, I just couldn't decide that I could be a single specialist and only dealing with a particular area, and thought general practice would work for me. It also was, I realised once actually I was in Maryborough and working as a junior doctor. I also met my now husband, and he was working in Maryborough as a physiotherapist, and we kind of decided that we'd probably like to stay here. We enjoyed being there, and if I did want to do another specialty, I'd actually have to return to Brisbane at that time. There was no choice. I would have to go to Brisbane. So this is, just a while ago. Still have to go back to the metropolitan locations for many specialty trainings, but things have improved, and we need to push for more improvement in that space. But nonetheless, for me, it went, well, I don't really want to go back to Brisbane. I loved living in Brisbane when I was a student and an intern, but I'd now decided that I really quite liked the casual lifestyle and the minimal traffic and the short commute to work. And so we decided to stay in Maryborough, and that sort of firmed up my decision to choose general practice, because I could easily remain there for the longer term as well.
I see.
So it was a career that would suit me. And obviously I thought I'd have children. Thankfully, I was able to have children. So I was able to then blend those two careers of having, being a mum, as well as being a GP, and now adding in my academic work. At the end of medical school, I had no idea I was going to work for the University of Queensland ever again. I just got my medical degree from. I was leaving UQ. That was it. I'd had enough of medicine, enough of universities. Learning, but it's interesting how life, courses opportunities. The opportunity to start up the Rural Clinical School site in Hervey Bay was provided for me, and I thought, oh well, why don't I give it a go?
So you were effectively heading it up as a pilot program and everything, like from.
It had already been started so we had Bundaberg, Rockhampton, and Toowoomba were already established, and the year that I started with the then director of the whole Rural Clinical School together, we started up the Hervey Bay site. Yeah, so I started with 8 students for the first year in 2005, and now we have 28 students who can be learning with us full time here in Hervey Bay.
Right. That's really cool, because then that must be great too, because like, I mean, as a GP, you know that you're really directly interacting with your community, but on top of that, that must be such a satisfying process to go through, because now you've got a hand in kind of like the next generation almost, you know, like this, it just seems like a nice natural progression of how you can continue to have that impact, like still practicing general practice, but then also kind of guiding the next cohort of students that will hopefully continue to practice in the Hervey Bay area as well.
Yeah, we certainly hope so, and that's our goal. And even if they don't end up all remaining here or returning here, and we have had some who've returned, if they're serving another rural or regional community, that's great too, because you know, certainly across Queensland and across our footprint there, we all have workforce shortages. There's not enough doctors, you know, in our regions at all, and in our rural communities even less in many of them. So yeah, I don't mind if they go to another rural or regional community. We'd love to have them keep here in this region, but they can go elsewhere as well, as that's okay.
Yeah, and you mentioned before as well that there's a shortage of GPs in the Maryborough Hervey Bay area. I've been trying to kind of build my own awareness of rural practice, because being in a metro area, I'm really not very well connected with it, even in Victoria. But I have come across this general trend that even though GP specialties are probably the more available in terms of specialty training in rural settings, there still seems to be a shortage of GPs in a lot of rural and regional areas.
Yeah, absolutely. We're you know, probably not producing enough GPs, and a lot of our GPs that are in our communities are older and retiring. And we're not having the same kind of replacement. So whilst you know, the rural generalist program, which is where GPs, rural generalists get a GP qualification and an advanced skill, certainly have helped in many rural communities, you know, by providing, being able to service and work in the small rural hospital, as well as providing primary care. But I guess the model of working compared to back in the day, where you had single doctors, you know, working in, you know, it's not single, doctors working as in a single, one doctor in a town is what I'm trying to say.
Right.
And so they work 24/7, you know, and that kind of model of work is just not, you know, sustainable, and certainly
especially with rising populations as well.
Yeah, and these days is just not, you know, we know that it's not safe practice. You know, people need time off, and so, you know, what communities used to have one doctor, you know, really need to have now 3 doctors. Right. You know, as a minimum. So to be able to share the on call and have leave and those sorts of things. So and that's, you know, that's not anything trying to criticize the new doctors, you know, needing to have more in a town. It's just providing, ensuring safe practice. And it's not criticizing the old doctors either who were working there, because they were doing a great job as well. But it's just changed. Practice has changed and expectations have changed, which I think is, you know, completely fine. But yeah, unfortunately, not enough of our medical school graduates are choosing general practice careers at the moment. And you know, I think there's a range of reasons for that, including remuneration, I think, you know, and as well. So I think, you know, our specialists and non-GP specialist colleagues and hospital, you know, specialists, you know, have a good remuneration package, and which is fine. And in general practice, we know Medicare rebates have been frozen for a long time, and so there's been no rise of income, yet there's been rise of expenses. So, you know, it's been a bit challenging to attract, I think. But as I say that, I think I'm, you know, I feel like I'm appropriately remunerated, you know, in my regional community. I personally haven't found that a problem. And I think being there for so long, you're a really valued and respected member of the community, which is nice as well. But you also feel like you're giving back to that community, you know, appropriately and effectively as well.
Yeah. And I think, well, I had it further down in terms of what I wanted to ask you about with the RMP program now, the regional medical pathway that UQ is now offering. Because obviously we're seeing a bit of a trend. I think UniMelb and Flinders are the other 2 universities that have invested a little bit more in now actually having end-to-end medical training in rural settings, to hopefully see greater retention of the graduates and for them to practice and then spend hopefully their entire career in that setting. Do you think, obviously, UQ obviously does think that this is a really good sustainable way of going about it? And I was looking into some of the research, and it seems to show that it's just that there seems to be a general relationship that those that actually start and end their medical training entirely in that setting seem to then have better retention in those areas.
Yeah, so that is what the evidence shows us from elsewhere, and within Australian research, as well as in Northern America and US and Canada, that the longer they are in the regional areas or rural areas, the more likely they'll return to that area or a similar sized area as well. So it's not always the same area, but another area. I mean, we know from our own statistics at UQ, if a student, our latest sort of statistics say from in recent times is that if they've been with us for 1 year at the rural clinical school, around about 28-30% of them are working, choose to work for their internship in a rural regional area. But if they've been with us for 2 years, it's nearly 60%. So it almost doubles.
Oh, wow.
So that impact, and we also know that our graduates. Long term, we have a long-term tracking study, and about 40% of our graduates over 16, 17 years are working in rural and regional areas who have been RCS at the rural clinical school, compared to if they've only had metropolitan experiences, it's around the 17-20%, somewhere around that. So it's definitely,
that's quite a significant jump.
Significant more. So we know that it works even in what we're doing, but the evidence suggests that if we can have the whole training in the regions, that it's more likely. But it also means it's more accessible to rural kids. So one of the challenges and barriers for people is actually having to go to Brisbane and paying for accommodation. It becomes a lot more expensive to go, to do medicine if you live in Rockhampton, if you've got to and go to, or if you come from Emerald and you've got to go to Brisbane for at least 2 years, and that's a lot more expensive than living at home, or living closer to home where rents might be a bit cheaper as well. So not only do we think it'll increase and improve retention, but it improves access to rural and regional kids to actually study medicine. And then I guess we know that many of them will choose to either remain or return at some point down the track to their home communities. At the same time, there's no expectation that they have to, but we just know that over time that they'll more likely to return. And we really think that this model of enabling students to do their undergraduate degree in that region and then join us at UQ for their medical degree, and then support them to find career pathways. So as I was saying before, having more specialist training places available in those regional hospitals. Sure, they may need to do some time back into a metropolitan and tertiary hospital, but if they could be based in the regional hospitals rather than based in metro and have to come out, if we can flip that model more and have them based in the regional hospitals and then be able to do what they need to do in metro for shorter times, then have them based there, they'll have established their connections. They'll feel like a sense of belonging and connectedness to that community. And we know then they're more likely to stay.
And so does that mean, I'd imagine the data is showing as well that with that issue, with the kind of bottlenecking that's happening with specialty training, and then obviously it's more exacerbated in regional settings with less programs available, does it look like effectively people that might be practicing or doing their junior years in a rural setting are then following the training program to metro areas, and that's where we're seeing a shortage as well? It's kind of
we do. Exactly. It's those junior doctor years. It's where we lose them. You get a lot of graduates, medical students, and then 1 or 2 years out, they're working in regional and rural areas. But then it's then that they return to the metro sites. It's often at that point we lose them because they feel they need to go to the metro to be able to get onto specialist training programs, to find pathways. And they're not available not as many of them are available. If we could increase that and look at how we can change that specialty training model to have more in the regions, then I think it'll help those regional hospitals as well. You've got the strong junior staff to support the specialist staff. If specialist staff don't have a lot of junior staff and people who are training in their specialty, so they've got to give a lot more supervision. It's a lot more work for those consultants and specialists, whereas if they've got the training pathway but supporting them, then they become able to have a better quality of life with their specialist work. Similarly to their metro colleagues who have, their on-call ratios and all of those things that are lesser. So I think it helps the whole system if we can have more of those, that cohort of junior doctors, particularly who are training in a specialty area, because their skills are increasing as they go through their training program, of course, and expertise, and that takes the pressure off the specialists as well a little bit as well. So I think we call this the end-to-end program, and our end-to-end means from end of high school to end of fellowship training. So it's supporting them, our graduates, all the way to the end of their fellowship training. So that's what we want to do. And that's the ethos there. And if we can get as many homegrown ones who are from those regions, then hopefully that will work to make a difference. And obviously we've got our partnerships in Central Queensland and Wide Bay is one of our medical pathways. We also, and that's with our partners are with CQU Uni, which is the regional university there, as well as the two health services of Central Queensland and Wide Bay. And then we've also established the Darling Downs and Southwest medical pathway. And so so that's with USQ, University of Southern Queensland University, and then the two health services of Southwest and Darling Downs. And so we're doing a similar model of medical pathway of end-to-end training there that will be just commencing next year. So our CQ Wide Bay commenced this year with the first intake of students in the undergraduate program, and we're hoping next year that our Darling Downs Southwest pathway commences. So we believe this will make a difference, and hence are investing in the establishment and implementation of the pathways.
And in terms of the cohort size as well, so it's I think if I got it right, it was 90 places, but there seems to be a flexibility to raise that to 120. Is that right?
So what it will be is that in CQ and Wide Bay, there'll be 30 students, who will be based in Central Queensland and 30 in the Wide Bay. And then in the future, then there'll be 30 in the Darling Downs Southwest. So it'll be 90 it'll be 90 students. But we still will have opportunity for metro-based students to have rural and regional learning experiences as well.
I see. So someone could do, say, a long-term placement with the rural schools, even if their main training is through the Brisbane.
There may be capacity for that, or there may be shorter term placements. So we're still finalising some of that. Obviously, the students who are part of our medical pathways in the regions will definitely be based there, but they'll also get opportunities to go to metropolitan as well if they wish. So, for shorter blocks, and so that will still happen. That metro-based students will have opportunities to have both probably more shorter term rural and regional experiences, although possibly some longer term, like year-long placements potentially as well as time goes on.
And so I'd imagine, I don't know a huge amount about the UQ program at the moment, so that would probably be increasing its capacity to incorporate rural training or rural settings into the 4-year degree as well.
So it's a 4-year degree. Sorry, I'm not quite understanding your question. Sorry.
Yeah, so sorry, I might not have worded it very well. So in terms of the program at the moment, like prior to the RMP, is there a compulsory or an elective rural placement as part of that degree at the moment?
Yeah, so as part of our RHMT funding, we actually have to have 25% of our graduating cohort have spent at least 1 year at a rural clinical school. So at the moment, we actually, this year have at the moment 164 students learning and with us across the rural clinical school sites for the whole of the year. So that will increase, obviously, once we've got 4-year cohorts of the 30 in each of our locations. So we'll be having ultimately 360 students learning with us each year once we're all fully up and running. So it'll be about doubling what we do now. And so we'll get those experiences. So at least 25% of all students get a year-long experience, and almost 100% of our domestic cohort, and I think it's around 95 on average, have a 6-week short-term placement in their 3rd year of the medical program currently. So we get over about 250 students, 260 students every year get at least a 6-week placement as well.
Wow. Okay. Yeah, those are quite large numbers, because I know UQ has quite a large cohort compared to some of the other graduate programs as well.
Yeah.
So I would hope that all of that investment is going to pay off, and we're going to see a lot more people, starting and ending their careers and
Yeah.
continuing it all the way through in regional settings as well.
Yeah, we still hope so. And
Yep.
we'll keep working at how we can tweak and improve things for student experience, and support them in their junior doctor years to enable that and facilitate that as best we can.
Yeah.
We can't always control what happens in life. Life happens, and
No.
and as well, when we recognise that too.
Yeah, absolutely. And so now jumping back a little bit just to the specialty of GP, the first thing I guess is, because part of this podcast is to kind of give people insights into exactly what the practicalities are of pursuing a particular specialty. A lot of people that watch are currently in the application process, but some are already in their first year of medicine, and many over the next few months will then be gaining entry into a lot of different programs. So for those that are interested in following general practice, what's the training pathway? We'll start, say, from graduation from medical school. What does the training pathway look like?
Yeah, so you need to obviously complete your internship, and as you might be aware, that as of from 2024, the internship will become a 2-year program in Australia.
Oh, I did not know that.
Yeah, so
Okay.
So 2024 intern will become a 2-year program. And then it's after that doctors, will be able to apply for general practice training. I actually would recommend. And then you do a year in hospital as part of that training, and then you go out to general practices, and you have your basic terms and advanced terms. And in your GP training, you need to have gone, at this point in time at least, you need to have at least 2 different practice experiences in your training, and some will have more than that. That can be a bit of a challenge sometimes if you're in a rural area, though, and there might not be another practice to go to, or
right.
So there can be. So those are some of the challenges in some of the smaller rural communities if you're training as a GP in those. But that can be negotiated. But next year, the other thing that's kind of changing at the moment a little bit in general practice training is that currently the training is undertaken by what's called regional training organisations, and it's now being returned to the colleges, to both the RACGP and to the Australian College of Rural and Remote Medicine. So they'll be the profession-led training instead. But the program will still be the same, even though the model of training and the training providers might just look a little bit different to what it does now. But essentially, yes, you have your hospital terms for about a year, and then you go into your general practice, your basic terms, and then your advanced terms, and then you have another year. So it's 4 years of training all up for the GP.
Okay.
I would recommend, I think where you learn such a great wealth of medicine is in those junior doctor years at the hospital as well. So I reckon, I think at least having at least 3 to 4 years in the hospital system, learning and seeing that real breadth and wealth of clinical experiences, it's really good grounding for good general practice as well. If you try to get out too soon, I think you miss some of that learning you get in the hospitals. It really does help you, I think, to have a good breadth of good sound knowledge. It's those couple of years, it's those 3 or 4 years that you really, from what you learn in med school, there's a lot to learn. But you just consolidate that learning and put it so much into clinical context and practice that it just really gets embedded in your brain so much more, so that, I think then of course, whilst you're in general practice, you see it all as well and you learn a lot. But I think it's great to kind of do, I would probably recommend, if you can, is sort of have that, from in the future, 2 years of internship, and then probably a couple of years additional time in the hospitals before joining general practice. But one of those hospital years is part of your general practice training, so that's okay. You can apply, and you still have
and you can include that in it. Yeah.
So it's I think it's good grounding, and but you do see a breadth and wealth of clinical cases and clinical stuff, I guess, in general practice. So well, I guess it goes back to what you're saying at the start, that in a single day, you don't know what's coming next, and it can be so variable. So there's
it seems almost near impossible to get the same level of exposure and preparedness for that kind of variability in the training in even if it was now the extended 2-year internship. It would just take time and just to see lots of different departments, lots of different patients.
Yeah, absolutely. And I think the other thing around, I was just going to say, in general practice, you see that variety, but it really is a change in how, in the hospital, you've got a lot of colleagues around you, you've got nursing staff that support you, you've got the allied health there if you need them, and obviously you're more senior doctors. It is quite a change when you come into general practice because it's just you in the room with your patient. And it can be initially quite sort of a bit daunting, I think, sometimes. And you need to be prepared that it's a different way of practicing medicine. It can take a little while. And the other thing that I think sometimes can maybe concern, people thinking about general practice is that uncertainty that you don't know what's coming through your door, and a bit like an ED department, it maybe not quite as acute as EDs. Sometimes it is, but you don't know what you're going to be seeing next. And for some people, they can initially struggle with that level of uncertainty and not knowing really what the patient's going to be coming.
Yeah, I'd imagine having that you've got a much more direct responsibility. Like you'd still be working, I guess, as a team, but it's a very different kind of teamwork, isn't it? Because in a hospital setting, you'll be working in consultation with others, and you'll often be getting other opinions, and there'll be a lot more collaboration. Whereas in GP, you might have a much more direct interaction with the patient, and in terms of the decision making, right?
Yeah, you do. And of course, though, as a GP registrar, you've got your supervisor and your other GPs that you can talk to and seek advice. There's no problem with that. But nonetheless, when you're in that room and the door gets shut,
it's just you and the patient.
It's just you and the patient. And that's quite different to being in a ward and looking after people. There's always somebody around. There's not often, there are private rooms, obviously, in hospitals too, but it is a different kind of feel. And sometimes initially, I think, some GP registrars can find that a bit challenging, and not having that support network kind of as visible, perhaps. It is there, but it may just be in a different way, and you just need to acknowledge and accept that it is in a different way, and that you can still seek all that help. And even though the way general practice set up is not as conducive to feeling like you can always do that. So I think you just need to understand that the support is always there still. It just looks a little different.
Yeah, the setting itself, I guess, just plays out differently. Yeah.
And that uncertainty. And the other thing about uncertainty in general practice is that you often end a consultation with uncertainty. you haven't always solved everything in one consult. Whereas in the hospital, if an inpatient, for example, they stay there and you might be waiting for results and so forth. But in general practice, you might actually send somebody out the door, still not really sure what's going on. Because you've got to wait back, you've got to wait for some results to come back, you've got to wait for, maybe the evolution of something. And for some people, that initially can be quite challenging too. And it's getting used to and getting comfortable with that uncertainty. Of course, you've made sure you haven't missed any red flags that need urgent attention and all of that. But it can be sometimes hard for people, especially for us as medicos who want to solve things and want to know that we've made a diagnosis and we've done this.
I never thought about that reality of it, because you kind of just think that like the job of a doctor is to fix the problems, like they fix health problems. And it's not that you're not fixing problems. It's just that some problems take time. And as you said, sometimes you have to wait for test results or for more evidence to support a particular theory before you go kind of gung-ho with it, so to speak. I never really contemplated that. That would definitely take some adjusting to. That would be one of the unique elements of GP work, I guess, compared to hospital work. But it's just getting used to the difference when you're first as a junior doctor, as a registrar coming into that kind of practice. Obviously, for us who've been doing this for many years, that is the way of general practice, and you get used to that and you accept that, and it's fine. But it can be a trap for young players, perhaps. Well, that's good to know. Yeah,
that they might feel they should have made a diagnosis. They must be doing something wrong if they haven't by the time the end of the
but it's just part and parcel of the way that it works. Cool. All right, well, I might end it here on one final question, because I know I don't want to take up any more of your time than we need to. So I had just at the end a question for people that, so we can have some advice for people beyond all the advice you've already given and all of the insights, which have been great. And this is partly a personal question for me, because being someone who will hopefully be in medical school next year, somewhere in the country, I don't yet know where.
Good luck.
I know, unfortunately, I wasn't able to put UQ in my preferences because I was unfortunately just not competitive enough. And it was a real shame because it was absolutely on my radar. And I wanted it to be, like Melbourne has to be number one for me, just because I'd love to not have to leave my home state. But UQ was really going to be number two. And unfortunately, it didn't work out for me with my results. But in terms of people that are going to then be on their GP placements while in medical school, and I guess this could also be for anyone that's watching that is maybe even doing GP rotations in their internship right now. What would be your advice to that person in terms of the best way they can really like take advantage and draw things out of that experience?
Yeah. Look, I think no matter where you are in your clinical experience, the more you get engaged, the better experience you'll have. Don't sit in the corner and be a wallflower. You'll never learn much that way. Talk to your GP. I think it's really important to talk to your GP supervisor and say what you want to get out of it. Spend some time thinking about what you want to get out of this, because you're the only person who knows what you know well yet. Obviously, you don't always know what you don't know, of course, but plan your learning a little bit, plan what you want to get out of it. So not just expect the GP to tell you, oh, you're going to learn this. Take some time. Then when you're in the general practice, get engaged, see if you can actually talk to patients on your own, present them to your GP. And obviously, if you're having a consultation with the GP, work out how you can work together to ask the questions and be involved actively in that. Yeah. Take opportunities as much as you can to take histories. General practice is a great place to learn and hone your skills of history taking, remembering that history taking is the core skill of medicine, not just general practice, but in medicine in general. If you've taken a good history, 80% of the time, you will nearly know the diagnosis at the end. If you're relying on investigations and examination and investigations as the thing to help you all the time, you're not going to do well. And it's not going to be rewarding for you in the long run. So good history taking, jump into that, do the procedures, once if your GP is a procedural GP or, does things, try to do as many practical things as possible under supervision, of course. And just, I think the other thing in general practice, if you can, is really get to understand the patient, how illness affects them, and impacts on their life, on their quality of life, get a real understanding of, we often think about medicine and understanding disease, how we're going to treat this and treat that. And that's good. You need to know that. But you always have to put it into context of the person. You have to practice person-centered care to make a real difference. If you just plonk, this is the way we manage diabetes and that's what it is, without considering the person's context, it never one size fits all in medicine. And general practice is a really good place to be able to see that in action. And sometimes students can actually look at something at a GP and go, oh, they're not quite following the rules. What's going on? It's actually because they're putting it into context for the patient. Yeah. It's actually making sure that it's going to fit and the patient's going to follow their advice. It's person-centered care. And sometimes you might kind of, as a student or even as a registrar, but as a student, you might sometimes kind of think that's not the right way to go because you heard that you should do this and that when in your tutorial. It's not following the rules, but it is around being person-centered, and the way you get to understand it is really just talk to people about their lives as well. Take that opportunity, as well as talking about their illness and their history and their symptoms and medical history and all of that stuff, but also the social history, which we always should do, not just in general practice, of course, even in hospital medicine. But it's a good opportunity to talk about that and, and then understand how disease and illness impacts their quality of life as well. And I think that helps you be a better, broader, more well-rounded clinician as well. Even if you choose not to do general practice in the end, that'll hold you in good stead in the non-GP specialties as well.
Yeah, perfect. That's really great advice. Thank you so much for your time today.
Thank you for seeing if I could help out in the podcast.
It's been hugely helpful. And I think the biggest thing for me personally has just been so eye-opening. This is exactly what I wanted to get out of these conversations, is I think it's one of the most efficient ways to learn about something Sometimes medicine to me feels a little bit behind closed doors. And I think that, and it's not that it's intended to be that way or anything, but I think that just being able to have a conversation like this and hear what your career has been like, it's very inspiring to hear as well. To hear like things like the continuity of care, the fact that you've stayed in direct contact and serving the one community for your entire career is something that I think a lot of people should aspire to as well. And I know that's something that I'm really dedicated to. I don't yet know where that's going to be or what that will entail. But that to me is something that I will take as a piece of guidance in my own career planning. So thank you for all the advice today.
If I could just add there, whilst that's worked for me to be in this one community, I appreciate that for some. The great thing about medicine, and I think in many specialties and general practice and others, is that you can mix it up and do whatever you want in the end. Just about flexible. You can do it. It's really flexible if you want it to be. This has worked for me to do this career that I have, and I'm really happy with it. But that's the beauty of medicine. It allows you so much flexibility. And I think always my advice to people as well is to keep your mind open. And if a door opens, don't be too hesitant to not enter. Go in and see what it's like. You can always walk back out if that's not, what you think you want to do in the long run. And that's what I did with when I started working for the university. I had no idea that I really wanted to be an academic, but now I love it. I'm really glad that that door opened for me and has given me so many opportunities over, the last, how long have I worked for them? 17 years now.
17 years.
17 years that I've worked for the university. I would never have thought that was when I graduated, as I said before. But I just think, keep your mind open in all placements and in all jobs, and when you're working to learn as much as you can from your colleagues, from your patients, and take steps forward into open doors and see where they take you. And all the best in your travels.
Yeah, thank you very much. Hopefully it all goes very, very smoothly. We'll see. I just finished my applications last week. So now it's a big, long wait until interview offers start. So we'll see.
Good luck.
Yeah, thank you very much.
Okay, thanks.
All right,
bye.
No worries. See you later, everybody. I hope you enjoyed this episode of the Dissecting Medicine podcast. Please leave me a comment with your thoughts and share this episode with others that might benefit. Otherwise, thanks for listening, and I'll see you next time.